A 58-year-old woman drives to the grocery store. In the parking lot, her right hand suddenly feels like it belongs to someone else. Numb, strange, not quite there. She shakes it out. It passes in 2 minutes. She goes inside and buys her groceries. 36 hours later, she's in the ICU, unable to speak. The hand. That was her warning, and she had no idea. I'm going to make sure you never miss yours. I'm Hameed Ullah Shaheen, a neurologist, and I want to talk to you today about the gap between what people think a stroke looks like and what your body actually does in the days before one happens. Because here's the truth most health content glosses over. Stroke is rarely a surprise to your biology. It is almost always a surprise to you, because nobody taught you the language your brain uses when it's in danger. That changes today. The two-stage reality of stroke. Most people imagine stroke as a single catastrophic event. One moment fine, the next moment devastated. That is the second stage, and by the time it arrives, the window for easy intervention has often closed. What very few people visualize is the first stage, the weeks, months, sometimes years of arterial damage quietly building inside the walls of the blood vessels feeding your brain. No pain, no visible symptoms, just slow, progressive narrowing. And then, before the final blockage, your brain sends distress signals. Medicine calls these transient ischemic attacks, TIAs. The word transient is the dangerous part. It means temporary. It means it goes away, and that is exactly why people ignore them. In the 72 hours following a TIA, stroke risk spikes dramatically. That window is not a medical footnote. It is the most important window in stroke prevention, and most people spend it convincing themselves that what they felt was nothing. Let me show you what nothing actually looks like. You are reading, watching television, or simply looking across a room. Without warning, a gray or black shade seems to fall across one eye. Not both, just one. Like someone dimmed a single lamp. It lasts perhaps 30 seconds, maybe 90. Then it lifts completely. You blink. You look around. Everything seems normal. You move on. What just happened inside your body was anything but normal. The eye has its own dedicated artery, the ophthalmic artery, and it branches directly off the internal carotid, the same artery that feeds the front of your brain. When a tiny fragment of plaque or a microclot breaks loose from a buildup in your carotid and travels upward, it has two possible destinations, the eye artery or a brain artery. The odds of which one it hits are essentially anatomical chance. When it hits the eye, you lose vision temporarily and it returns. When it hits the brain, same clot, 2 millimeters over, you lose speech, movement, or both, and it may not return. Doctors have a Latin term for this one-eye blackout, Amaurosis Fugax. In any emergency neurology context, that phrase triggers immediate, urgent evaluation. Not come back next week. Immediate. If you have ever experienced this, even once, even months ago, that information belongs in front of a neurologist. Warning sign 2. One side stops cooperating. Pins and needles in an arm you slept on. Everyone knows that feeling. It is dull, predictable, and clears up the moment you shift position. This is different. You are sitting upright, fully awake, not leaning on anything. Without any trigger, one hand, one arm, or one side of your face begins to feel distant. Not quite painful, more like the signal is getting interference. Numb, tingly, heavy, or wooden. It might last 3 minutes. It might last 8. And then it dissolves, and you feel fine again. The reason stroke symptoms appear on one side of the body comes down to basic brain anatomy. Each hemisphere controls and receives sensation from the opposite side of your body. When blood flow drops in one hemisphere, even briefly, only that side's territory goes offline. Both hands going numb simultaneously usually point somewhere else. The cervical spine, a nerve compression, circulation issues unrelated to the brain. But a sudden, unprovoked, one-sided numbness that self-resolves in under 15 minutes is a textbook TIA presentation. The critical distinction: this is not about position. It is not about activity level. It appeared without a reason. That is the red flag. Warning sign 3, your balance gets hacked. You are walking a route you have walked 1,000 times, and suddenly your foot comes down wrong. Your body lists sideways. You grab the wall. For a moment, the room tilts even though you are standing still. Or you are sitting at a table and a wave of violent spinning hits you from nowhere. Not the gentle swaying of a head rush, but a hard, disorienting rotation that makes you hold the table edge. It passes in minutes. You blame dehydration. You blame blood pressure. You blame age. But here's what was actually happening. Deep in the back of your skull sits the cerebellum, a dense cluster of neural tissue responsible for one thing above almost everything else: coordinating where your body is in space and translating that information into smooth, accurate movement. The cerebellum is supplied by a separate vascular system from the one feeding the front of your brain, the vertebrobasilar system, a network of arteries that travels up through the vertebrae of your neck. If blood flow in that system drops suddenly, the cerebellum glitches. It stops receiving the real-time positional data it depends on. And the result is exactly what it sounds like when your GPS loses signal. You veer, you stumble, the world appears to spin. This is not inner ear dizziness. The difference matters. Inner ear problems typically have a trigger, a quick head turn, rolling over in bed, a known Meniere's condition. Vertebrobasilar TIA dizziness is spontaneous. It arrives without a trigger, and it is often accompanied by that instability of gait, the slightly drunk walk on a flat, familiar surface. That combination, sudden spontaneous dizziness plus unsteady walking, should not be self-diagnosed as tired feet. It should be evaluated. Language breaks down. This one people often dismiss because it is embarrassing to report. You are mid-sentence in a conversation. Suddenly, the word you need is simply not there. Not at the tip of your tongue, not anywhere. You substitute a wrong word without realizing it, or you stop and cannot restart. The other person looks confused. You feel confused. It passes in a minute or two, and you laugh it off. Too much on my mind, not enough sleep. Or the reverse. Someone speaks to you, and for a moment, the words land as meaningless sound. You understand that language is happening, but you cannot decode it. Then it clears. There are two speech processing centers in the brain, both typically in the left hemisphere. One, classically called Broca's area, manages word production, the mechanics of converting thought to spoken language. When blood flow drops here, you know what you want to say, but cannot execute it. Words come out slurred, incomplete, or wrong. The other, Wernicke's area, manages comprehension and the meaningful organization of language. When this region is deprived of blood, a person may speak fluently, but the content is scrambled, real words assembled into sentences that mean nothing. They often do not realize it is happening. Here is the rule I want you to remember. Tip of the tongue moments that resolve slowly over seconds when you are tired, when a name simply does not come, that is normal aging. But sudden, complete, inexplicable language failure that resolves in minutes, that is a neurological emergency, even after it resolves. Do not wait for it to happen twice before asking about it. Warning sign 5, new headaches that feel wrong. Your entire life, your headaches have had a character you recognize. They arrive predictably, they respond to whatever you usually take, they leave on schedule. Then something changes. A headache appears that feels categorically different in location, in intensity, in quality. It does not respond the way headaches usually respond, and it arrives alongside some of the other things we have been discussing: transient vision changes, numbness, instability. This combination deserves medical attention, not because every new headache signals a stroke, but because headaches caused by vascular changes in the brain can have a distinct quality that people often describe as the worst headache of their life, or simply as unlike anything before. There is an important distinction here. Many chronic headaches originate not from the brain's blood supply, but from the cervical spine. Degenerative changes in the small joints between the upper vertebrae can refer pain into the skull reliably and repeatedly, and have nothing to do with stroke risk. Ruling that out matters, and a doctor can help you do it. But a headache that is genuinely new in character, especially in someone with vascular risk factors, especially paired with other transient neurological symptoms, is a conversation to have urgently, not at the next routine appointment. What is actually destroying your vessels? None of those 5 warning signs appear in healthy arteries. They appear in arteries that have been under assault for years, often quietly, without any alarm. What does that assault look like? The inner surface of every artery is lined with a single layer of cells called the endothelium. When it is healthy, it is almost frictionless. Blood components slide past without catching. Nothing sticks. 2 things damage that lining faster than almost anything else. The first is chronically elevated blood sugar. Glucose is fuel, but in excess, it is also corrosive. High glucose levels physically damage endothelial cells, causing them to swell, malfunction, and eventually die off in patches. Those bare patches become landing zones for cholesterol particles and platelets, the raw materials of arterial plaque. The deceptive part? This process does not begin at the threshold of diabetes. It begins in the pre-diabetic range, blood sugar levels that many people carry for a decade without ever being told they have a problem. A simple blood test called HbA1c tells you your average blood sugar over the past 3 months. It cannot be gamed with one good morning result. It is a 3-month biography of what your blood sugar has actually been doing. Ask your doctor if you have had one recently. The second major threat is tobacco. Every cigarette delivers a chemical assault directly to the endothelium. Compounds that cause inflammation, damage the surface cells, and simultaneously make your blood thicker and more prone to clotting. A damaged vessel wall plus sticky blood is the precise combination that produces a stroke-generating clot. The risk reduction from quitting is substantial and begins quickly. Blood pressure adds a layer of complexity that most people misunderstand. Yes, hypertension damages vessels over time and is a major hemorrhagic stroke driver. But here's the part that surprises people. Ischemic strokes often happen not when blood pressure peaks, but when it drops. If your carotid artery is already narrowed 60 or 70% by plaque, it is like a garden hose someone is pinching. While the pressure in the system is high enough, some water still passes through. When pressure falls, during sleep, during dehydration, after certain medications, the flow through that narrow segment may stop entirely. This is why some people go to bed with no symptoms and wake up or are found by a family member having had a stroke in the night. The natural blood pressure drop during sleep, combined with a pre-existing narrowing, can tip a compromised artery into full occlusion. The 3 tests that change everything. If anything in the warning signs we discussed sounds familiar, whether it happened last week or last year, there are 3 investigations worth bringing up at your next medical appointment. First, carotid duplex ultrasound. This is an ultrasound of the main arteries in your neck that is capable of doing something a standard ultrasound cannot. It shows both the structure of the vessel and the behavior of the blood moving through it. A skilled sonographer can identify where flow accelerates through a narrowed segment, quantify how severe the narrowing is, and help your doctor determine whether the plaque is stable or the kind more likely to fragment and travel. When narrowing exceeds roughly 70%, it crosses into territory where intervention, a surgical procedure to clean out the artery, can be more protective than medication alone. That conversation starts with the ultrasound. Second, HbA1c blood test. One tube of blood reveals whether your vessels have been quietly dealing with elevated sugar for months. It identifies prediabetes years before it progresses. And identifying it early is precisely when lifestyle changes, before medication may even be necessary, can reverse the trajectory of endothelial damage. If you have never had this test, or if it has been more than a year, it is worth asking for specifically. Third, 24-hour Holter monitor. A standard ECG in a clinic lasts perhaps 15 seconds. Many dangerous heart rhythms are intermittent. They appear for 30 seconds twice a day and are invisible to a snapshot recording. The most important rhythm to catch is atrial fibrillation. In AFib, the upper chambers of the heart quiver chaotically instead of contracting in organized beats. Blood pools and swirls rather than flowing cleanly, and clots form with alarming ease. Those clots travel directly to the brain. The defining feature of AFib in many people, they barely feel it. Occasional flutters, a strange heartbeat for a moment, something blamed on coffee or stress. A 24-hour recording worn during a normal day catches what a clinic visit cannot. And if AFib is found, anticoagulation, blood-thinning medication properly prescribed and monitored, reduces the associated stroke risk by 60 to 70%. That is not an estimate. That is what the data consistently shows. What to do right now? If any of the 5 warning signs I described have happened to you, even once, even briefly, even months ago, write it down today. Not a mental note, actual words on paper or your phone. What it felt like, which side of your body, how long it lasted. That description is the foundation of a proper neurological evaluation. A doctor cannot adequately assess a risk you cannot describe accurately. At your next appointment, ask 3 specific questions. Should I be evaluated for TI given what I experienced?
Is a carotid ultrasound appropriate for me? When did I last have an HbA1c? And should I have a Holter monitor? These are not aggressive demands. They are the right questions. A doctor who takes your history seriously will take these questions seriously too. And if you experience any of these symptoms right now, while they are happening, that is not a call the doctor tomorrow situation. That is an emergency room situation. The 72-hour window is only useful if you enter it. Stroke is not fate. It is not random. And for the majority of people, it is not silent. It just speaks a language nobody taught them. You now know that language. A gray curtain over one eye. One-sided numbness without a cause. Sudden instability on flat ground. Language that briefly breaks down. A headache that feels categorically different paired with other symptoms. Any one of these, in someone with vascular risk factors, is a message from your brain that deserves to be taken seriously. Not because panic helps, but because action in the right window genuinely changes outcomes. The 58-year-old woman in the parking lot, the one whose hand went strange and came back, her outcome was not inevitable. Her window was real. It just went unused. Yours doesn't have to. If this gave you something genuinely useful, share it with someone in your life who is over 50. Not as a scare tactic, as a gift of information. Subscribe if you want more of this. Complex medicine made clear, without dramatization.